Hi guys. Hey guys. Were you guys waiting not all that time? Hello, hola.
Yes, I was waiting.
That's so weird. I literally was sitting here waiting too, and it just started showing people requesting. Well, sorry about that.
I thought I got the military wrong.
I was like, man, I am really unpopular.
I had to ask other people. I was like, do I know military time or is this wrong? I don't know.
Well, if it makes you feel any better, I still don't know any the military time. I had to check like 3 times.
I did too. Verify with multiple people. I was like, am I
So we're
wrong?
on the same page.
Yes.
All right, guys. Well, nice to meet everyone. So just to tell you guys a little bit about myself, I am in mental health, so I'm just a term ahead of you all. I just finished my med surge this past term, so a week ago, 2 weeks ago. How long was that ago? I don't know. But I am not 100% knowledgeable on everything, but anything I don't know, we will find an answer to together. And so let's start by, who do you guys have as professors?
I have Roses.
Roses? Okay. I had Garcia. Does anyone have Garcia? Is she even teaching?
She is teaching med surge.
She is. Okay. Yeah. I heard she was teaching only fundamentals. Okay, so let me post the. I'm sorry?
She's teaching fundamentals too.
An overachiever. Okay, so I'm gonna post the QR code right now, and please make sure you guys check in with that, otherwise I get in trouble. Let me pull that up and I'll share it on the screen, and then we'll get started on the tutoring, okay? That's funny, I totally was just sitting here waiting. Okay. So do you guys have a study guide? Did any of your professors provide a study guide for you guys?
Roses gave us like a review session where she was kind of like a study guide. I had a class today, so this was like week 2 stuff.
Got it. Okay. And do you want to post what she gave you? We can go down the list. We can do it that way, or I just kind of just start tutoring from the notes that I have as well.
I mean, I just put in the chat everything that Roses told us that we need to know for next week.
You got it.
But I'm not sure if anybody else is trying to learn still the first week stuff, like if they have class tomorrow or the day after.
So we're looking, yeah, so we're gonna be focusing on this first week, and then we can get into that if no one has any questions about the quiz for perioperative nursing. So if you guys have a quiz for this week, questions for this week, let me know right now. Otherwise, we'll move on to next week, which I'll have to get my notes for that.
Well, my class is on Friday, so Thursday, so I haven't taken.
You haven't had the quiz yet. Got it.
Yeah.
Okay. So we'll go down, and I'm still trying to figure out how to share my screen on Zoom. Do you guys know?
I think there's a button that says share content at the top. I'm using my iPad. I'm not sure how it shows on yours, but I'm pretty sure that's it.
Figure it out. I'll figure it out here in a sec. Why don't we get started, and I'll just post a QR code at the end, since we're already a little behind. All right, so perioperative care. So I did really horrible in fundamentals. Like I struggled the whole term, and I realized in med-surg that there was a couple of things that once I figured out made the biggest difference in med-surg. And when I'm talking about how it helped me in med-surg, I'm really talking about how it helped me in test taking and ATI. And the things that I'm referring to is, have you guys heard of EAT, what that means? The acronym EAT? Anyone know?
No, that doesn't sound familiar.
Okay, so EAT means, and I'll type it in the chat, EAT. So what a nurse can do, right? What the responsibilities of a nurse are. Because there's always, I don't know if you remember questions from fundamentals, there's always a question, there's always several questions that ask what the different responsibilities of the different types of nurses, right? We have the RN, the LPN, and the CNA. So a nurse is always going to evaluate, so that's what the E is for. Assess and teach. So anytime you see a question on an exam, you're always going to remember this EAT. If it's not an evaluation or an assessment or a patient teaching, then that's a job that's deferred to an LPN or CNA. So that said, going back to fundamentals and the priority setting framework and Maslow's hierarchies, are you guys familiar with that?
Sorry, with what hierarchy?
Maslow's hierarchy. I don't know if you remember that from a little bit. Okay, so this, and I don't even know to this day what all the hierarchies are, but I know that the first one is physiological needs, right? So when we're talking about nursing, the most important thing that a nurse is always going to do before she takes any action is, what is it? What do you guys think it is? The number one thing that a nurse always does, if we're thinking about ADPI, right? What would you think? What would you guys think it is?
Assess.
Mm-hmm. Exactly. So so if assessment is always the first thing you're going to do when there's a question about a nurse sees a patient with chest pain and left arm pain radiating to the shoulder and up the neck, and then the answers are, she's gonna call the doctor, she's going to administer medication, right, Andrea? We're always going to assess the patient first. So just remember that, please, because honestly, I swear to God, that made the biggest difference, and never question that. So if you always assess first, no matter what the answers are, you go with the assessment first, okay? Yeah, exactly. And I would get so confused for fundamentals, because I'm telling you, fundamentals, I almost didn't pass the class. And then I got into med-surg, and I realized that as long as I remember assessment first and our ABCs, do we know our ABCs?
Airway, breathing, and circulation.
Right. So airway, breathing, and circulation. So assessment, evaluation, teaching, that's always going to be the RN's job, right? That's always going to be our job. And then ABCs. So if you ever see a question that has the that has, you know, a patient comes in with they're diabetic, you know, and they tell you like their blood sugar is 300, but they're, you know, and they have shortness of breath and they're anxious. What are you going to do first? Are you going to address the glucose, or are you going to assess their, and that's a
breathing.
question. Exactly. So ABCs always first. So always remember that. That's always priority, ABCs, Maslow's hierarchy, and that falls into Maslow's hierarchy of needs in the physiological, right? So you want to make sure that the person is that's breathing. So we're talking about airway. So is their airway patent, can they breathe? And breathing, how are they breathing? Is it shallow? Is it tachycardic? So, you know, are they breathing quickly? Like, you want to assess their breathing. And the circulation, that's the third. So we're talking about their circulatory system, right? So what are they experiencing? So those little tidbits, they're going to make the biggest difference. And then the other thing that helps too in test taking, and I'm referring to test taking mainly right now before we get into perioperative, because that's really what helped me the most. And I did really well in med-surg. Obviously, that's why I can spread the love that I got from tutors in the past to you guys. Is just remembering those three things. The third thing is acute versus chronic. So if you get a question with, you know, you have patients that come in and they have different patients. The acute patient, so if they say a patient comes in with an acute condition where, you know, they have shortness of breath. It's always shortness of breath somehow. And then you have a chronic patient with COPD, you're always going to see the acute patient first. So that's always going to be a priority. And there is a cool test taking PowerPoint that usually Bernie provides for you guys, who's the NCLEX tutor. I think he's still the NCLEX tutor for your fundamentals. And I can also send it to you guys as well. So I can send that via email after I get the QR code out to you guys. So you guys can look that over, because that helps with test taking, and that's going to be monumental and scoring better on your tests, because that helped me a lot. All right, so let's get into perioperative, and then we can get into next week's if we have time. And if we don't have time for next week, when is your exam, Andrea, for the second week?
Mine's on Tuesdays at 7 a.m., but it's okay. I don't mind reviewing again.
Okay, cool. And then I'll definitely share a link to these ATI notes. Has your professor mentioned the proctored ATI test at the end of the term?
Yeah, it's like related to fundamentals, right?
Exactly. So that is a huge part of your grade. So start studying that now. And by studying, I mean like read a chapter of your ATI's fundamental a day. You don't want to wait till the last minute, because that can make it or break it for you, even if you have a high grade up until that point. But I'll also share some really awesome notes I found for the ATI proctored exam that helped me a lot as well. And I got a level 3, which is the highest you can get. So there's tons of resources, guys. And they make a big difference. Go to all the tutoring sessions. Go to mine, go to the other tutor session, go to the NCLEX. Literally the best thing you can do, since we have those resources available, take advantage. Because I'm telling you guys, I struggled in fundamentals. I barely passed. And then med-surg, I just took advantage of all the help that was offered. So let me pull up my notes. Let's get going. So perioperative care. What can you guys tell me about it? Have you guys read the book? How are you guys approaching your studying?
I'm just going based off my professor's lectures, like hearing those and the PowerPoints.
Okay. So surgery settings. What is an elective surgery? What does that mean?
Elective is like plastic surgery.
Right. So, but what's the difference between someone getting plastic surgery and someone that goes in with the chest pain, right, and is taken to
it's like threatening versus like non-threatening.
I would say it's more planned versus non-planned, right? So an elective surgery is a planned surgery. And I only see, so I see Andrea's name. Is that Manifa? Is that a name? Is that your name, or is that a? Oh, okay. What you were asking about med-surg? What? What about med-surg though? NCLEX. Oh, got it. I think Andrea must be talking about fundamentals because.
Oh, no, I was talking about my test today because I did the 120 today, and I studied mainly the NCLEX and ATI, and I got like a pretty high score.
Oh, good. Okay, awesome. Yeah, so you're taking advantage of all the tutoring and stuff. Yeah, it makes a difference. And then it kind of depends on too what your preferred method of studying is too. For me, it's literally rewriting my notes. Okay, so going back to elective surgery. So elective surgery is planned surgery, right? So it's the surgery that's planned in advance. And then what's emergency surgery? So what's the difference between elective and emergency? I just said it.
One is planned and one isn't.
Correct. Simple. So emergency surgery is unexpected surgery. Ambulatory surgery is same day or outpatient surgery. So these tend to be more like endoscopy clinics, physician offices. I'm volunteering at a orthopedic surgery center right now. So surgeries where literally someone comes in, gets the surgery done, they're in the post-op room, recovery room for like an hour, and they get sent home. So what is the difference between urgent and emergent surgery? Does anyone know?
Would emergent be like you came into the hospital needing that surgery, and emergency was like it was scheduled?
So urgent versus emergent, and emergent is basically just another word for emergency. So urgent is it's when urgent means it's urgency, right? But it's not an emergency because the patient is medically stable. So they're a priority, but there's someone else that's more of a priority. But it's something that needs to get done within a few days. So anytime they're talking about an urgent medical condition, means that it's prioritized and it needs to has a certain set of time that it needs to get done at, but it's not a let's get that done now situation, right? So emergency, obviously that's a life or death situation. So every time there's an emergency, we're talking about a life or death situation with the patient. All right, so let's get into the preoperative nursing responsibilities. So what do we know about informed consent? What do we remember from our intro to nursing, professional nursing, nursing 110?
The doctor has to be the one to explain the procedure to the patient, and the nurse is there as a witness.
Correct. So, and what is the nurse witnessing?
The nurse just has to witness that they are the ones actually signing off for their own procedure. And then also that they are like consciously aware of what their procedure is.
Right. So that they are they understand and they are competent, and this is the key word, is competency. So is your patient, what's your patient's LOC? Are they are they signing just because they feel pressured because you're standing there? And I don't know, maybe they don't speak English, they just don't even really understand, they're just signing because that happens a lot. I mean, I'm Central American. My parents speak Spanish, and there's definitely a couple times that I've watched my parents, or more my mom, sign off on things in a medical setting without really understanding what she's signing off on, right? So the main thing you want to remember about informed consent is, number one, a nurse's responsibilities is only to make sure that your patient understands and is competent. So they're clear-headed, they know what they're signing off on, they understand the procedure, and that they are signing with that knowledge. If there's any reason to suspect that they are not competent, then it is your responsibility, right? So the nurse's responsibility is to be I'm blanking on the word. You're responsible for this patient. You want to make sure that they're taken care of, and that means even when they're signing something. So you want to make sure that they're competent, right? Now, what do you do if a person or if a patient is signing a document and they're like, I understand the surgery, but I still have a couple of questions. Can you answer those questions for them?
No, you would have to get the surgeon or the doctor in charge to answer those questions.
Correct. So there you go, that's the word I was trying to remember. Advocate. You're the advocate, so you want to make sure that there's no doubt in the mind of your patient when they go ahead with this surgical procedure. So blood transfusions. What is a religion that is against blood transfusions? Right, Jehovah's Witness. So in terms of a nurse's responsibility when it comes to a surgical setting or a setting in general at all where you might need a blood transfusion, your responsibility is to have that blood ready. So if a patient's going to need some kind of replacement, you need to make sure that those bags are ready for the patient to use once the surgery starts, right? So you want to have all your stuff, all your equipment ready, basically, or all your are your tools ready? So blood transfusions, you want to make sure that that's ready and that you have a consent signed for that as well, because that's a separate consent. If they are a Jehovah's Witness, you want to be culturally mindful of that and make sure that you are advocating for them if they don't want that. If they don't want a blood transfusion, they don't want a blood transfusion. So what is the power of attorney? And why is that important in a surgical setting?
The power of attorney is someone that, like, in case the person doesn't have consciousness and they can't make decisions for themselves, then they have appointed the power of attorney to make that decision for them. But in that case, is that when the nurse has to have 2 witnesses, or is that just for court ordered?
That is the form that wait, no, the power of attorney is a court ordered document. I think you're thinking about the advance directives. So power of attorney, advance directives versus power of attorney. Power of attorney is, you're appointing someone through the court to make the important decisions from you when you are unable to do so, right? Advance directive, which is another thing that we need to make sure we have when it comes to honestly any kind of clinical situation, and especially like in emergency rooms and operative situations, is a advance directive is basically something that the patient fills out it's a guideline for the doctor and all the clinical staff to follow in terms of how to treat this patient if this patient all of a sudden can't speak or is in a situation where they can't really express what they want. Josefina, yes, there is. I will be posting that towards the end. So advance directive. So is everyone clear on power of attorney versus advance directive? Power of attorney is a court appointed document that designates someone else to be responsible for you, and advance directives is just guidelines that you preset in case there is a situation where you can't speak for yourself. Okay, so we'll move on.
Okay, sorry. So quick question, is that only 1 nurse needed to see the consent, or is that 2 nurses?
So no, so it's not a nurse, it's just 2 witnesses, period.
Oh, okay, so it doesn't have to be a nurse to witness it?
You can be there, but you don't necessarily have to be a witness for it.
Oh, okay, got it. Thank you.
You definitely have to be a witness. I mean, you have to be there to witness the consent. That's definitely number 1 priority from this point forward. Anytime we're talking about surgeries or any where there's a procedure that requires consent, the nurse's job will always be to have a consent. If you don't have a consent and all of a sudden and you're in a situation where the patient, and another thing to remember about consent is, and here's the question. So let's say if a patient's going into surgery, right, and they've already administered the anesthetics, which means their LOC is going to be altered as soon as you administer that medication, right? What do you do if you don't have an informed consent, if you forgot to have it signed? Can you still have this patient sign the form?
No, right?
Nope, you can't, right? Because your job is to, your job is basically to be this person's like guardian angel. So if they are not competent, right, then therefore they cannot sign a document giving permission to go ahead with something. So in that case, you would tell the doctor that you forgot to have this paperwork signed, and then go from there, which I'm sure is going to happen to all of us at some point. But you tell the doctor, okay? And a family member cannot sign for someone in a consent form unless what?
Unless they're in that advance directive, right?
Well, more of a power of attorney, actually. Cool. All right. So, so let's see. So in terms of preoperative nursing assessment, things that are very important is establishing baseline data. And what I mean by that is, you know, you want to make sure that if this patient has any pre-existing conditions that you are assessing and getting all this data, right? You want to know, you know, if this person has a heart problem, you want to know that, right? Because you want to make sure that you know what his normal is compared, so you can compare it after surgery to make sure that everything's okay. So establishing baseline data is very important in the nursing assessment for a preoperative patient. Going back to LOC, right? You want to make sure that this patient is aware what's going to happen, that they're in a good state of mind, that you know, they understand what's happening, and risk factors. So allergies. What allergies should we ask about, or should we be concerned about for a surgery, or any situation where, right, latex allergy, any situation where a patient's going to be going under, put to sleep, right? So latex allergy. So let's say someone comes in and tells you they have allergies to certain food. What food, like what type of food would you hear that would trigger a correlation between a latex allergy? I don't know if you've learned about this, but there's certain types, there's certain shellfish, right? So shellfish allergy is one. Remember that, guys. That's going to come up a lot in med-surg exams and ATI exams. So shellfish. What else? There's a couple. So shellfish. Another one is bananas, avocados, kiwi, and there's definitely a list. Let me see if I can find it. There's a list of a couple of things actually that I'll have to look for it, but the main things that will always come up on exams is banana, avocados, and latex. So if anyone says they have latex, avocado, banana, or shellfish allergy, then you know that that person has a latex allergy. So if that's the case, then we want to make sure we note it in there, we document it, and also make sure that any cords in the surgical setting. So let's say like the cord that whatever equipment they use, like the power cords, those are made out of rubber that have latex in them. So if that comes into contact with the patient, then it can cause an anaphylactic reaction, right? So we want to make sure that we protect them by wrapping those cords in stockings, so stockinettes, which is basically what they put on patients for circulation on the legs. So like they're really like tight, right? Exactly. They're really tight socks that they can wear, stockings. So shellfish allergies, avocados, bananas, indication of latex allergy. So what about asking for if they take any supplements, right? That would be another thing that we need to consider. So that's always a question that you want to address when it comes to surgeries. Do you guys know what, right, herbal supplements. Do you guys know exactly what herbal supplements we're talking about? There's specific ones that are, right? And why is garlic something that we need to be mindful of? What does it do? Do we know what it does? So it would be garlic. So garlic, and I'll put in, actually I'll type it in the chat. Garlic, fish oil. So I don't know if you guys take fish oil supplements. So if a patient says that they take a fish oil supplement, you want to make sure of that, because that, along with garlic and ginkgo, correct, increases bleeding post-surgery. So basically they can have a they have a risk for bleeding because it thins out your blood, basically. So those are things you want to remember too from this day forward. It will come up a lot in ATI and future exams this term. So those herbal supplements. Now, and then what else? So it's ginkgo, and then St. John's wort. It's another thing that we need to be aware of. Cranberry, yeah. So if you guys look at your med search book on page 302, they have a list of all the things that we need to be aware of for patients. And this list, like I said, will follow you guys till the end of time. So that's definitely something I would become very familiar with, especially ginkgo, garlic, St. John's wort. So St. John's wort will come up a lot. Is something we need to be aware of because it can prolong the effects of the sedation. So if a patient is taking St. John's wort before surgery and you don't know, then opioids cause respiratory depression, and this can prolong that as well. So you want to make sure that they're not taking this, and if they are taking this, does someone know what the recommendation is in terms of when to stop these supplements prior to surgery? And I would say it's more like 2 to 3 days, but I would say more of 7 days. And then, so it's ginkgo, ginseng. I think that's it. And then in terms of medications, what medications would we ask the patients to hold? So we asked warfarin. Yeah, warfarin. You'll definitely know what warfarin is by the end of the term. So warfarin, digoxin. So basically you have all your clients hold all meds except for their heart medications. So heart medications I'll take up until the day of surgery, okay? So that's important to remember as well. So what's another thing in terms of someone with going into surgery, or even one of our jobs as a nurse is to make sure that we have the right patient, right? So what do you do to ID a patient to make sure that you have the correct patient? What are the things that you check? Right. So name band, date of birth, medical number, those are going to be always the name band, and always their name and date of birth for sure. Okay, so let's see what else. So what are the laboratory diagnostic tests that we want to make sure that we're checking before a surgery? There's a bunch. So ABGs, right? Their pulse oximetry, so we're looking at their oxygen levels, their respiratory function. If they have diabetes, we want to make sure that their blood glucose is taken before a surgery. Their urinary diagnostics tests, do we know what those are? What are the two tests that test renal function? Oh, yep, you got it. Bun and creatinine, correct. Those are the two tests that will always be looked at for renal function. Right, lipid panel, the HCG, pregnancy. So that's another important one. Pregnancy, if a female is of an age that she's having intercourse, potentially, you always want to make sure you get a pregnancy test done before surgery. Can anyone tell me why? Why is that so important? That's super important.
Not to damage the fetus.
Correct. Exactly. So, you know, you're going to be using, or they're going to be using very intense drugs. And if you guys are in pharmacology this term, you'll learn more about them. But these drugs, you know, the sedatives, they can cause a lot of harm to a fetus. So you don't want to find that out after surgery that the patient was pregnant, because that's a big deal. And it's, you know, not only is it devastating for the mother to be injured or might be injured, but also it's a huge liability for the hospital. So that's always something to remember. But anyway, the point to all these diagnostic tests is what? We want to establish baseline. And why do we want to establish baseline? Because after surgery, the best way to take care of someone is by knowing what their normal is. So we know when something is abnormal. Right. I mean, you want to know, you can't know if something is abnormal if you don't know what normal is for someone. Someone can have, you know, can have a lower blood pressure just regularly. And if you see a low BP, something crazy like of 90/60, which might cause some alarm. But if this patient is just kind of, that's what their baseline is, then you know that you don't have to worry about it. But the only way to make sure of that is by having all your documentation and making sure that you know where they started at. So patient teaching for anxiety, right, with a patient, or to decrease their fear, right, of the surgery. What would you guys teach? What would help someone? Yeah, definitely you want to be open about, you want to have open communication with them and make sure that they're expressing any kind of fear that might have, any questions, right? If they have questions, you refer them in terms of the procedure, right? You refer them to the doctor, but if it's just something that just requires a therapeutic ear to them, then that's your job. Coping techniques, right? So more so than just talking about it, I'm looking for coping techniques like deep breathing, right? So have you guys gone over your deep breathing techniques? Do you remember this from fundamentals? Incentive spirometer, correct. So that's guided imagery. And this is stuff that's going to help after surgery as well with pain, right? So another important thing to remember about pre-op or just patients in general when they're in a surgical setting or even in the hospital setting is medication reconciliation. Do you guys know what this is? And what that means, basically, what your job?
Is that when you match the medication with the doctor, with the physician order?
That's
Whatever
so
the physician orders meds?
yeah, so basically is you want to have correct guys. You want to make sure you are aware of all the medication that this patient takes. So you want them to, you know, if possible, if they're going to have surgery, you want to make sure that they bring their medication bottles with them, so then you know exactly what dosage, what they're taking. You want to have a list of all these medications, right? And we're also talking about supplements, right? Herbs and vitamins, because now we're going back to the ginkgo and the, you know, the fish oil. We went over informed consent already. So factors that can affect, and I'm just going down my notes, guys. If at any point you guys have any questions, just let me know. Factors that can affect patients' ability to learn, stress, right? If they're in pain. So if someone's in pain, you can't really expect them to comprehend, not even comprehend, but have the ability to pay attention to you if they're too something going on in their body that's causing them huge discomfort. That's something to be aware of. So if there is ever a question that talks about, you know, a patient is just reported having pain and they have to sign their consent form, what are you guys gonna do?
Do we wait until they have calmed down for a while?
Definitely. And if they're in pain and you're expected to have this, you know, even the doctor surgeon is expecting you to have this consent form signed, then what you do is you inform the doctor that this patient has pain or is experiencing discomfort. So then the doctor can prescribe something to help them get to a point where they're not in that condition, so that you can make sure that they're competent again to be able to sign this paperwork, to make sure that they understand, and that's like the only thing that they can that is a priority to them at that point. All right, so let's see. So intraoperative care. Any other questions on pre-op? Yes, so the this is the first time PALS is doing this, because I know last term for my med surge, they didn't have this available, but now this term they're starting to, so all the recordings for all PALS tutoring are going to be posted on a YouTube page for the school, and they'll be up there for the rest of the term. And then once the term ends, they'll be deleted, and then it gets replaced with whatever new. Right. So it's always good, honestly, because we are stuck at home and we really don't have that hands-on experience. To this day, I haven't had any clinicals. Recordings, going back and listening to lectures and tutoring has been a huge difference. I'll post that link. Actually, let me post that link right now. Let me get that for you guys. And then guys, this quiz, honestly, MedSurg starts with a pretty easy pre-op or perioperative care is, in my opinion, one of the easier quizzes that you will have for the term, because then you guys start actually getting into the systems. I have to look through like millions of PALS emails. And then once you get into the other stuff, you'll definitely, I mean, it's going to get a little bit more complicated for sure. All right, guys, I'll have this all ready for you guys next week. I'll be more prepared. All right, so here's the link for the YouTube. So, and then the PALS team will automatically post this. This is all done by someone else. But that is the link that you guys use to look at the tutoring sessions, okay? And like I said, I would highly recommend attending different people, because different people, obviously, we all study different, we all remember different things. And that was a huge thing for me. I took advantage of all the tutors. All right, so let's keep going. Yeah. Kyle is probably, because we're only on the second, wait, this is the first week of PALS, so there was no PALS last week, and today's only the second day of tutoring. So I think the intro to MedSurg tutor of the week, if I remember correctly. So I wouldn't expect anything to be up yet for MedSurg anyway. And if for some reason there's nothing posted on there tomorrow, I would, you guys can email me, or I would email PALS directly, because they're like they're the magicians taking care of everything, okay? What was the other thing I was going to tell you guys? You guys so go on Etsy, which I know it's random, right? I only found this out. Someone else in my cohort told us about this, and that's what helped me pass the ATI. They have basically someone typed out all the notes for ATI and for different classes, and they're sold, and it's only like $4, and it's like a PDF that you download. I would highly recommend, because there is MedSurg Etsy. I don't know the link. I would just go to Etsy. Like, doesn't everyone know what Etsy is? They sell everything there. Go to Etsy and just look up ATI fundamentals or ATI MedSurg, and they have awesome notes that you, and obviously they're not going to be like super elaborate, but they're a great starting point if you're having, because I know for me, one of the issues I have is I get anxious about not studying the right thing, which I'm sure it's very common. But it gives you more of a, it kind of just structures things more so you can focus your attention a little bit more, you know? So I would highly recommend, especially the fundamentals notes for your ATI exam. Oh, and then I'll also give you guys, here, I'll post a link right now. This awesome lady, and I know I keep going back to the fundamentals exam at the end of the term because it's a big deal. Like it literally can, you can have a B+ all term, and then if you don't do well in this, you can still fail the course. So I'm gonna give you guys the link of this lady that goes down the ATI, goes to the ATI fundamentals book chapter by chapter, and like the videos are on like 5 minutes long, and it's really good review as well. So if you just want like an outline of how to approach studying for that, she's awesome. I watched her videos, and you can just listen to them in the car because they're super fast. So here's the link for that. So this is the link for all right, so those are 2 resources for studying for the ATI, guys. That are big. Okay, so we are at intraoperative, right? So what's the difference between, so this is for Josefina, this is to study for the so at the end of your med surge in week 8, everyone takes a proctored ATI exam, which is a national exam. I'm sorry? I'm explaining to Josefina what I'm talking about in terms of the study materials I'm giving you guys. It's a national exam that everyone takes across the nation, and it is, so there's 3 levels to it: level 1, level 2, and level 3. And I think level 1 is like 60, I can't remember, but it's like level 2 is 60 points, level 3 is 120 points. I mean, that's that huge of a difference. So if you get a level 0 or a level 1, you're literally losing about 100 points in your critical grade, which can be a huge deal for people, you know, when you're trying to pass with the 76 and above. So what those study materials are, so you can start prepping for that, because you're literally going to be tested on all the fundamentals material from this past term. Okay, so let's keep going. All right, so what's the difference between a scrub nurse and a circulating nurse? Who knows? Correct. So that's the main thing. So a scrub nurse is in charge of the sterile field. Correct. And circulating nurse is the non-sterile portion. So in a surgical room, there's always an area that's marked off. So everything inside this area that's marked off is sterile. So if you're in there, you're going to be in full PPE. all your gloves are going to be sterile as opposed to non-sterile, right? So they're going to come in that little envelope that maybe you practice in your fundamentals clinical. And then the circulating nurse is in charge of the non-sterile area of the surgery, and also documentation. So those are the two main things. So as long as you remember that scrub nurse is in charge of the sterile team, the sterile field, and the circulating nurse is in charge of this non-sterile area and maintains documentation, you'll be good on that. So do we know what the different areas of the surgery room are, or the surgery center are, and what they mean? So, well, we have the, right, so unrestricted. The unrestricted is, what does that mean? So we have unrestricted, restricted, semi-restricted, yeah. But what does that mean, right? So unrestricted means you can wear street clothes to scrub, so you can walk in your regular shoes. This usually involves like the holding area, the nursing station, and then the semi-restricted, you have to have appropriate PPE, which means if, right, there's a red line where you can pass. And semi-restricted is you want to wear surgical attire, so you're wearing your scrubs, depending on, and this is going to vary depending on the facility that you're in, but pretty much what you want to know is that unrestricted means you can wear street clothes. Semi-restricted, you have to have appropriate clothing for there. Now, the restricted zone for the OR means that we are wearing sterile clothing, and by that we're talking about full PPE, and that is your bouffant, which is basically the little hair bonnet thing that they give you, sterile gloves, you're wearing the gown thingy, you're wearing covers on your shoes, so everything you want to make sure you maintain sterile from your toes to the top of your head. Any other questions on that? No? Okay. All right, so different types of anesthesia. So when is moderate to deep sedation done? So moderate to deep sedation is done for procedures done outside of an operating room, right? So that could, right, conscious sedation. And so that's any procedures done outside of the OR. So let's say, so I actually went to a dentist today and to get a teeth cleaning, and they did local anesthesia on my gums. So that would be an example of moderate, I'm sorry, of sedation done outside of an OR. Right. So monitored anesthesia care, that's used for procedures like endoscopy. That would be a monitored anesthesia procedure. And that's done in or outside of the OR. So that's more diagnostic testing and therapeutic procedures. General anesthesia And this is usually the anesthesia of choice if you're having a surgical procedure. And they can do, it involves skeletal muscle relaxation. And it's done when the procedure is going to be uncomfortable and there's going to be an incision done, right? And a procedure basically where you have to control ventilation. So you want to control the airway, because if you're applying general anesthesia, right? What does anesthesia do to the to someone's breathing?
You said general.
Mm-hmm. General.
Does it slow it down?
Right. So it depresses your respiratory system, right? Right, because it relaxes everything. So that includes your lungs, your diaphragm. So general anesthesia is when you have to control or keep track of how the patient's airway, basically going back to the ABCs. You want to make sure that they're breathing correctly, and if they're not going to be breathing normally, then you want to make sure that it's being monitored. And that's where anesthesiologist comes in. By the way, a nurse anesthetist is the type of nurse that makes the most money, if anyone wants to do that. I think they average around like 180 to 200K a year, which is pretty awesome. But you need a master's for that, FYI. Is it a doctorate program now? I thought it was just, I thought you had to be an MP and then do a specific, oh, they changed it? I think they're changing. I don't know if any of you guys want to become a nurse practitioner after the RN. But yeah, I know that they're changing their requirements. I'm definitely going for my NP after this. But I know they're changing things in 2025. So if you want to become a nurse practitioner, you have to do it before 2025. So it's not a doctorate that's required. Like if they require a doctorate, I'm not doing it.
If you do it, Jennipher, if you do it after you're done with being a BSN, do you need experience being a nurse first? Then you go to MP school, or can you just transfer over?
Well, hopefully, we're gonna have experience throughout our schooling, and I'm thinking, and that counts. So as soon as you start clinical, that counts as experience.
But I mean, we haven't been having any clinicals. So.
Yeah, so I would recommend, honestly, guys, I think it comes down to spending for yourself. Yeah, you do need, you're right, that you do need 2 years experience, but usually you get those 2 years experience even within school, right? Because technically we should be in clinical already. That's experience. So although I might have to check on that. I feel like I've read up on it so many times.
Well, West Coast has a doctorate program.
I mean, every time I'm like crying because, oh my God, I study all the time, and I start looking at how much nurses make. I'm like, all right, I'll keep going.
Yeah, it's worth it.
It's worth it. But so yeah, FYI, 2025, at least that's what I know, is it's the deadline for a nurse practitioner with a master's. All right, so I keep getting distracted. All right, so where are we? What are we, oh, okay. So circulating nurse, general anesthesia, local or regional anesthesia, a spinal tap, right? So local or regional anesthesia is, would be more like birth right, a nerve block. Right, so that's usually used in or that not usually, but that's an example of a female giving birth. They get epidural, right? So that's putting to sleep a part of your body, not generalized, right? Back pain. So another important thing for the perioperative care. So after the surgery is complete and your patient is in post-op, one of the things that, and this is definitely study this, is malignant hyperthermia, because that's going to come up a lot. Like anesthesia, most of this you guys are not going to see again, honestly. What you're going to see a lot of is the allergies, right? So consent, power of attorney, medications that you want to be aware of. So like heart medications, insulin if a patient is diabetic, those things, spend a lot of time on that, because you'll definitely see this again and again and again. Malignant hyperthermia is another one that's going to come up in a lot of exams. So do we know digoxin? Did you mean digoxin? I'll type it in. I don't know if I. Oh yeah, okay. I was like, I'm like, what? I never heard of that medication. Oh, I'll have to look that one up.
Yeah, it was like hydroxine or something, but it was supposed to be like, it's an anti-anxiety medication.
Okay, so I'm in mental health. Right now I'll be learning more about the anxiety medication. So I'm not really too familiar with that medication. But digoxin for med surg, digoxin, warfarin, those are gonna come up most probably every quiz. So malignant hyperthermia, do we know what that is?
Is that when your body your temperature increases?
Right. So it's something that you monitor, because I want to look it up so I can give you guys better information on that. So it's in your textbook. It's on page 325. So basically is a predisposition. So it's, if a patient is ever telling you that, you know, they had a family member who, when you're doing their assessment and taking their medical history, right, if that they had a family member with malignant hyperthermia, then that's a red flag for you, because it is there is a predisposition, and it does run in your family. So if your family member had it, then there's a good chance that you might have it, and it can be deadly. So it comes from, and I'm totally reading right off the book, it's a defect in hypermetabolism of skeletal muscle resulting from altered control of intracellular calcium. So as soon as this person receives the anesthesia, it's an effect of anesthesia, right? So as soon as this anesthesia is administered, it causes this reaction, and it leads to muscle contracture, hyperthermia, which is a very high body temperature, right? Hypoxemia, lactic acidosis, and cardiac problems, tachycardia, tachypnea, hypocarbia, blah, 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 blah. What you need to remember is that it's something that you want to make sure that you are aware of in their medical history before they go into surgery, so that if this person is predisposed to malignant hyperthermia, then the doctor knows, and you can prepare for that. Right, it's an anaphylactic. And then if you go to hospitals, or they actually have a cart, you know how they have a crash cart? They have a cart that is specific for this reaction as well. So there is a antidote for it. So if someone were to have an anaphylactic shock concurrent with malignant hyperthermia, there is a medication that will, no, it's not epinephrine, it's actually a medication, and I want to know if anyone knows. And I'll type it in. And like I said, malignant hyperthermia will come up a lot. So it's called dantrolene. And this is what is administered. So if a person has history of this in their family, then dantrolene will be the medication that is going to be prepared just in case that they have this reaction. And it has to be administered ASAP. If there's a sudden spike in temperature, that's like one of the first signs that you see. That's probably going to be on your quiz. Once again, like supplements, medication reconciliation, consent form, power of attorney. I'm betting that that's going to be on the quiz, and that's going to be in your ATI for sure. Okay, let's keep going down the list. Okay, so the goal of post-operative goal is you want a good handoff report, right? So if and there's different nurses, so there's going to be always going to be a pre-op nurse. There's going to be the circulating nurse, the scrub nurse that takes care of the patient during the surgery, and there's going to be usually a different nurse for post-op care. So there's always going to be a handoff report, right? And what's the handoff report called? Or how do you hand off someone? What is it that you do? Right, SBAR. And what does SBAR stand for? Situation, right?
Assessment and recommendation.
Correct. Surgical techs. Surgical techs surgical tech is a scrub nurse, basically. So in a surgical setting, you're either gonna have a you usually don't have both. Yeah, you have, and I know this because one of my best friends is a surgical tech, and I'm volunteering at the surgical center that he works at. So surgical tech is basically a scrub nurse that only does that. They're not, they don't take care of patients. Their job is to be in the surgical setting next to the surgeon, and they're the ones who keep the sterile field. They make sure everything's sterile, there's no contamination, and they hand off the tools. A scrub nurse's job is to make sure that the integrity of the surgical center, that the integrity of the surgical center is kept, right? So a scrub nurse / surgical tech is going to, if they see a doctor on, with their sterile gloves, touch something that wasn't sterile, as an advocate for the patient, their job is to tell their doctor, hey, I think you're contaminated. I still don't know how you would approach this with a doctor, but it is our job to tell the doctor, hey, like, I think we need to, we need to change your gloves or whatever. But yeah, so that's the difference. Surgical tech versus scrub nurse is the same, except one is an RN and one is a vocational person that just went to scrub tech school. Okay.
Well, I know that in American Career College, our sister school, there's a surgical tech program. That's
Yeah,
like
right.
2 years.
So that's what
So
that's what my friend did. It's a 2-year program, and the only thing he knows about is how to keep a sterile field in a surgery.
do they clean the instruments? Do they bring in equipment that they need?
They don't clean
Or-
the instruments. And don't quote me on that. They're not in charge, as far as I know, they're not in charge of cleaning the instruments. They're in charge of making sure that the instruments are sterile. So they're in charge of making sure that whatever instruments that they grab are sterile.
Because I've seen surgical techs, well, because I work at UCLA, and I've seen surgical techs with their carts and with their sterile equipment in it. So they bring them from a place where they actually go and clean them. So that's why
yeah, and that's going to be, and that's always going to be you know, and I've asked this question so many times because obviously we don't have access to clinical facilities. So at least on my part, I've had you know, I've had feelings of inadequacy because if you're anything like me, I learn best by doing. And I think if you're a nurse, you want to be a nurse, that's, you know, you're a doer. You're not want to sit at home and on the computer for 2 hours a day. You're a nurse because you want to be on hand, right? But what I've been told is that really wherever you end up working is where you're going to learn how to do everything the right way for that facility. So facilities will differ in how they do things. So the surgery center I volunteer at has someone designated to do the cleaning, and then the surgical tech literally like grabs all the sterile equipment that's wrapped in sterile plastic, et cetera, and makes sure that they have everything available for the surgeon during the surgery and that it's sterile.
You're right. Every hospital works different.
Yeah, and it's going to be, and even from hospital to hospital, I know I've been told, and I say I've been told because I myself haven't been in a hospital yet as a student nurse, and I've been told that every facility is different. So that's what, and you'll hear professors referring to, like, you know, they'll say something and then they'll tell you like, what, oh, it's, you know, a facility protocol. They always refer to that because what you learn here doesn't necessarily mean it's what's going to be observed or required at the facility that you end up working at. This is information to pass your exams and pass the state board exam, and fundamental information that you will know, but the rules and the type of protocols that you they want you to follow is going to be based on more so where you end up working. Okay, so and I wanted to make sure that I go over these things before we end because we have 15 minutes because these are going to be important for the rest of the term. Is complications post-op. So can anyone tell me what they are or what they might be? Pneumonia, yes. Respiratory problems, right? Right, that's what I was looking for. Atelectasis, pneumonia. The three, correct, paralytic ileus. So the ones that I want to focus on are pneumonia, atelectasis, a VTE, right? So venous thromboembolism, dehiscence and evisceration, and there's also hypovolemia, bronchospasm. This is another thing that you guys want to make sure that you really get down because it's going to come up a lot. And anytime a person goes into surgery for any reason, we want to make sure that we want to make sure that we are monitoring for this. So pneumonia. So why do you think pneumonia and atelectasis might happen? And we're thinking, and we start making the connection, right? What is it that happens in a surgery? What did we say that causes, right? So what did we say? What did we say that general anesthesia causes? Or even opioids, right? So an opioid can cause respiratory depression, right? And if you're laying on a bed, for long periods of time, then, and you're not breathing normally, right? So you're not getting that movement in and out, then there's an accumulation of mucus, right? That happens there. So pneumonia, accumulation of mucus, and how would you assess for pneumonia? What would be an indication in your assessment that this post-op patient that you just were handed off, maybe they might not have fever right off the bat, but there's something that you can definitely look out for that would point to pneumonia. And sputum, yeah, I mean, what I'm trying to get to is in your assessment, right? You're going to be listening to your lungs, right? Breath sounds. So what is the adventitious breath sound that would indicate pneumonia? Crackles, right? So if there's a question that says, you know, you have a patient who just got out of surgery and you hear crackles, then what is that something that you would have to look out for? It would be pneumonia and atelectasis. So atelectasis is a collapse of your alveoli, right? And what are the interventions for that, guys? So if turn every 2 hours, and what's something even simpler than that would be to deep breathing, right? So those are awesome. Those are definitely it. But the first thing you do is you elevate the head of the bed. Right, exactly. So your first intervention is elevate the head of the bed. And why we're doing that is because we're allowing more room for the diaphragm and your lungs to expand. So you want to help that person breathe as much as possible, right? And deep breathing exercises, you wanna turn them over every 2 hours, just like Josefina said. Guys, that's important. So study that, okay? So once again, herbal supplements. Oh, sorry about that. Herbal supplements. Oh. Let me put on my do not disturb. Okay. Herbal supplements, what I said, consent form, power of attorney, complications, pneumonia, atelectasis, VTE or DT, DVT. What's DVT?
Deep vein thrombosis.
Right. But what is it? So going back to,
It's pooling in the blood of the legs.
correct. So if someone's legs, right, have been laying on a bed for hours after surgery, then that circulation, and then the breathing's not happening as like it's used to, then there is a potential for a clot, right? So if a person tells you that their leg is feeling warm, that's a red flag for a possible embolism. And if it, what's the difference between a thrombus and an embolism? Do we know? So a thrombus is a clot that's stationary, and an embolism, it's a clot that's dislodged and it's traveling. So the risk in that is that if a clot travels through your circulatory system and it can get caught in your lungs, and then all of a sudden we have a pulmonary embolism. If it travels in through your heart and somehow gets through the circulation of the heart, and then once it goes to the aorta up to your head, right, then all of a sudden you can have a cerebrovascular accident, so you can have a stroke. So right. So and so what's our intervention to prevent someone from having a venous thromboembolism? Yes, ma'am. You know it. That's it. Exactly it. So you want to encourage early ambulation if that's possible. If they are for a reason bedridden and they can't ambulate, you want to make sure that they have the SCD, which I still have a hard time saying. Something. But yeah, SCD and the stockings, and that's going to promote the circulation in their legs to go back up to the heart and not pull. Yeah, Josefina, you got it. All right, so hypovolemia would be because there's too much blood loss. That's where we are monitoring for, if we're monitoring for that, we want to make sure that we have the fluids ready to go, or if they're doing a blood replacement, we want to make sure that we have that ready to go in the post-op room, right? So dehiscence and evisceration, what is the difference between those two?
Dehiscence, well, it's a wound separation, complete or partial. And then evisceration is protrusion of an internal organ. Or
Exactly. And how I like to remember is that evisceration, right, starts with an E. So, and then in an evisceration, the internal organs exit, right, the body. So what is the nursing intervention for either dehiscence or evisceration? Do we know? And like I said, guys, this list,
do we cover the sterile dressing with the moist, warm, sterile saline?
Right, so you're gonna soak a sterile dressing, not just the gauze, but it has to be in a sterile package, right? You're using sterile gloves. You're gonna moisten. It says moist, but my professor in med surg told me it's soaked. And
Okay.
why you're soaking? So look for either moist or soaked in your quizzes. The reason why you are soaking this dressing, it's because you want to replicate the environment of your organs, you know, right? So obviously in there it's wet. We have blood. We have all these different fluids. So we want to keep these organs that have exited the body moist so they don't dry up, because that can actually happen. So your intervention is moist or soaked sterile dressing with normal saline, right? Or a saline soaked dressing. And then, right, exactly. exactly what Josefina says. You put them in semi-fowlers and you want to flex the knees. And so the reason why you want to have your patient flex the knees, it's because it decreases the stretching of their abdomen. Because this usually happens, or this is usually a complication that's for abdominal surgery. So like gastric bypasses, situations like that. So you want them to flex their knees. So this area is not stretched out, right? And then the other thing you want to do is call the doctor ASAP. But the thing you want to remember is that you do not leave the patient alone. So you either scream it out, or you have someone else call a doctor for you. But that's important to remember. You do not leave the patient alone. All right, guys, so we're at 6:58 and I have to get that QR code for you guys. Yes, ma'am, let me get that for you. So just give me 2 seconds. Just need to. So you guys feel free to, and I'm gonna give you my, here's my phone number, Text me if you guys have any questions or like, want me to share any other resources that were helpful for me. Like I said, it was monumental for me to have tutors. They make the difference. And by tutors, I mean just other people that have been there before you, so they kind of know the pain that you're going through. And I'm a total airhead when it comes to this. It's not working. Hold on. Okay, here's the code, guys. Can you guys see it? So yeah, just make sure you sign in so I don't get in trouble. And I'll see you guys next week for gastro and endocrine. And hopefully I was able to help a little today. And sorry for the delay in getting you guys in here. I don't know what happened there.
Thank you, Jennipher.
Can you guys see it? You still need me to move it up? Yeah, you're welcome. Is that better? Have a good night, guys. Good luck. The pain.